Good afternoon, ladies and gentlemen, and Chairman. My name is Mr. Jaydeep Shah, and I'm presenting nerve injury following nerve blocks in knee surgery. Is it a tip of an iceberg? Our study was conducted in Princess of Wales Hospital and ABM University in Wales, United Kingdom. Peripheral nerve blocks, as we know, can provide adequate pain relief in post-operative pain in knee surgeries, and in combination, most of the time the femoral and sciatic nerve blocks are given. The nerves are identified nowadays using nerve stimulator or the ultrasound scan, and on an average the effect of nerve block can last up to 24 to 48 hours. Now the nerve injury, if it has happened, can manifest only after the nerve block effect has worn off, and which may take up to 48 hours. During that time the patient has to use the crutches, and this may result in delayed mobilization. Generally, the nerve blocks are quite safe procedure with low complication rate, which can range between 0 to 5% according to the New York School of Regional Anesthesia. The possible complications are listed here, but the most feared one is the intravascular injection. Now, ACL and MPFL reconstructions are commonly done in our hospitals, and the usual anesthesia is GA with nerve blocks. We have observed that certain number of patients in postoperative period were identified with problems of muscle wasting, quadriceps weakness, and the knee giving way. Now, the aim of our study was to analyze the problems associated with nerve blocks for patients undergoing knee surgery and to focus on the factors leading to nerve injury. The study was focused on the type of surgery, grade of surgeon and anesthetist, type of anesthesia given, the medications used. On the results, from June 2007 to August 2008, out of 100 ACL and 25 MPFL reconstructions, 6 patients developed complications of nerve damage. 5 were female, 1 male. They were quite young with mean age of 33. 4 had MPFL reconstruction and 2 had ACL. All were fit and well without any comorbid factors. All patients were operated in supine positions. All had GA followed by nerve blocks. This is very important. All the nerve blocks were given after the patients were administered anesthesia. And the different types of blocks given as mentioned, all the nerves were located with nerve stimulator, all the ultrasound. All the surgeries have been performed by the same consultant, while the anesthetic consultant and the grade of anesthesia was different. And you can see the different amount of anesthesia as well as the percentage of the drug was used. The recommended dose is between 20 to 40 mLs. 4 out of 6 patients had proven femoral nerve injury on EMG and nerve conduction studies, and the nerve conduction reports include severe axonal neuropathy to physical injury to the femoral nerve, and it is repairing itself. We need to find out what is causing the nerve damage. Is it a surgical complication, tourniquet injury, nerve blocks? Is it the patient position on table, or the medical status of the patient influencing nerve injury? If you look at the surgical cause, both the procedures require harvesting of medial hamstring, and saphenous nerve is very intimately related to the medial hamstrings. We have used Linvatec closed tendon harvester for all the procedures. If you look at the literature, there is a case of sciatic nerve injury as well as common peroneal nerve injury while harvesting the tendons, but there is no evidence of femoral nerve injury on hamstring harvesting. If you look at the tourniquet problem, we all know that if you use tourniquet for more than 2 hours with pressure exceeding 350 millimeter, then that increases the risk of compression neuropraxia. In our study, the tourniquet was used in 4 patients. The time range between 62 to 77 minutes, and the same tourniquet machine has been used, which was serviced and maintained every year. Is it a technical problem? Is the dose too much? Is it that the drug faulty batch? This study has been conducted over 14 months. Is it a faulty technique? The block in anesthetized patient can lead to increase in neurological complications. This is according to New York School of Regional Anesthesia. In conclusion, we can say that although only a small proportion of patients have been affected, this is a significant disabling complication to young patients. And these patients have neuropraxia due to nerve blocks. Is it a tip of an iceberg? As the nerve blocks are commonly used, especially in TKR and other knee surgeries, do they suffer from nerve damage? We have provided some recommendation after consulting with our anesthetic colleagues. They need to take the written informed consent. They should follow up the nerve block patients in their own clinic, and nerve blocks should be given in awake patients. Should change the needle from a long to the short bevel needle or round-headed needle with a side hole. There are other routine technical recommendations for giving the nerve block. Are they routinely observed? We don't know. We did re-audit our own study. After analyzing the 6 cases of nerve injury, we have modified our practice, and at the present, we are not giving any nerve blocks to the knee surgery. And we conducted a survey on a randomly selected 20 patients who have undergone ACL reconstructions. No new cases of nerve injury so far. Thank you.